Hello everyone, welcome to Surgical Insights with Dr.Deepz. Today I will be presenting a title slide of hemorrhagic shock. So I would like to go to the definition as I have mentioned here. It's acute blood loss which may decrease a circulating volume and perfusion, tissue perfusion, and finally that results into shock and end stage of organ and finally leading to death. Hmm? So hemorrhagic shock occurs when acute blood loss results in inadequate tissue perfusion and oxygen delivery. Okay, and if not recognized and treated promptly, it can progress to organ failure and eventually death. So here I have given you the most common points asked in most of the examination. Most common cause of shocks in trauma is hemorrhage, and the palpable femoral pulse requires systolic blood pressure greater than 65 mercuric pressure, and initial response to bleeding is generalized planchnic vasoconstriction via sympathetic activation. Okay, and small blood loss means minor blood loss results into renal perfusion and cardiac output maintained. Okay, and larger blood loss is due to activation of renin angiotensin system increase. Okay, and ongoing bleeding is actually a hemorrhagic shock. This is the thing you have to remember. But from surgical aspect, they may ask you the primary hemorrhage and secondary hemorrhage. Yeah, so they may ask you the basic definition, so you have to know it. So coming to physiology, as I discussed in previous slide, initial response to bleeding is due to generalized planchnic vasoconstriction via sympathetic activation. This aims to maintain blood pressure and perfusion of vital organ. Okay, and lesser blood loss. You have to also consider lesser blood loss and greater blood loss. And here, hemorrhagic shock is a form of hypovolemic shock. Another name is hypovolemic shock. I will be writing. Hemorrhagic shock is actually hypovolemic shock. Okay, hemorrhagic shock is also known as hypovolemic shock, and you have to know there is a similarity between hypovolemic shock and upcoming session cardiogenic shock. Most of the hemodynamic parameters are similar, but the causes are different. This is due to hypovolemia and that is due to cardiac failure. You have to know this causes. This may be resulting from trauma. Hypovolemic shock may be resulting from trauma, and cardiogenic may be resulting from cardiac failure to pump the blood, and eventually the blood hypovolemic shock presentation will mimic in cardiogenic shock. Okay, and here small blood loss may be due to renal perfusion and cardiac output maintained, and large blood loss may be due to activation of RAAS system that may actually vasoconstriction, sodium and water retention may increase the blood pressure and BP. Okay, the average adult blood volume is approximately 5 liter in 70 kg, 5 liter in 70 kg, and body initially compensate through tachycardia and peripheral vasoconstriction. Okay, peripheral vasoconstriction and tachycardia BP. Okay, and increase heart rate. Okay, and next is trauma patient presenting the shocks should be considered to have hemorrhagic until proven otherwise. You have to think about trauma patient, and confirmly there will be a hemorrhagic shock. You need to know. And three things I would like to tell you in this physiology. First is blood loss causes decrease. First is decrease preload, and second is leading to reduce stroke, and the third is leading to reduce cardiac output. Okay, this three is needed actually, very important. And here this blood loss causes decreased preload, leading to reduced stroke volume and reduced cardiac output. This three is very important hemodynamic feature. And to compensate the sympathetic nervous system, becomes activated, producing tachycardia and vasoconstrictor, as I discussed previously. And renin, angiotensin, aldosterone, and ADH are released to conserve the fluid. Okay. Another three you have to know: renin, angiotensin, okay, aldosterone, and ADH. ADH is antidiuretic hormone or released to conserve the fluid. This four are released to conserve the fluid. You have to know. If bleeding continues, compensation fails, and blood pressure falls, and organ perfusion decrease, and lactic acidosis develops. You have to know. If bleeding continue, once again I am repeating, if bleeding continues, compensation fails, and blood pressure falls, and organ perfusion decrease, and lactic acidosis develop. Lactic acidosis develops. You have to know. Next is you have to know about classification of hemorrhagic shock as per ATLS, advanced trauma life support. This is so class 1, it is supposed to be lesser than 750 ml blood loss and usually presents with a normal vital sign. Okay, and class 2 is 750 to 1500 ml, 1500 ml. Okay, presents with anxiety, tachycardia, and anxiety. Okay, and class 3 is 1500 to 2000, and here confusion develops. Okay, class 3, hypotension, tachycardia, and reduced urine output and confusion. You have to know. So in exam they won't ask you blood loss percentage, they won't ask you mostly this, and second, mental status they won't ask you mostly, and they will ask you blood loss in ml, pulse rate, blood pressure, respiratory rate, and urine output. From the surgical aspect, they may ask you. So, in case of class 1, again I repeat, pulse rate is lesser than 100. Okay, and you have a normal blood pressure, and respiratory rate is 14 to 20 bpm. Okay, and urinary output is greater than 30. Okay, 30 ml per hour. Next is class 2, you have to consider greater than 100, greater than 100. Okay, and blood pressure is normal here. Okay, and respiratory rate is 20 to 30. As if the respiratory rate, so is the urine output, 20 to 30 ml per hour. You have to know. And in class 2, it is. Rest of all, it will change. The more volemic hemorrhagic shock, the urine output will keep on decreasing. Okay, decreasing. Okay, and here is third class, 1500 to 2000 ml, and definitely you're going to have greater than 120 bpm, and blood pressure is decreased, and respiratory rate is 30 to 40, and the urine output is 5 to 15. Okay, this becomes oliguria here, oliguria, and in class 4 it is anuria, anuria. Okay, so in class 4, okay, class 4, it is greater than 2000 ml blood loss with greater than 140 bpm. Okay, and blood pressure is decreased here, and respiratory rate is greater than 35, and urine output is this thing, lesser than 5, anuria. This is oliguria, this is anuria. This is the thing you have to recognize. And symptoms, mental status is lethargic. Okay, and in class 3 it is confused, and in class 2 it is anxious, and class 1 is normal. In upcoming slide I will be putting a hemodynamic pattern to differentiate between hemorrhagic shock and cardiogenic shock, and rest of the shocks I will be teaching in upcoming session, including cardiogenic shock I will be teaching in upcoming session. And here's the cardiac output. You can see it is decreased, and cardiogenic, it is still decreased. Okay, and systemic vascular resistance, it is increased in hemodynamic, and cardiogenic is increased here. Okay, and heart rate, tachycardia in hemorrhagic shock, and similarly heart rate is tachycardia in cardiogenic shock. Blood pressure is again decreased, and here also blood pressure is decreased. So these four parameters are similar in both the feature because the causes is different. but ultimately central venous pressure in trauma is usually low, and pulmonary capillary wedge pressure is also low. Okay, and cardiogenic, the central venous pressure is high and pulmonary capillary wedge pressure is high. So these are the similarities between hemorrhagic shock and cardiogenic shock. One of the reason for hemorrhagic shock is trauma. They will definitely give you the accident case or hypotension case or any other case they may give you. Then in case of cardiogenic, one of the important is cardiac failure. Any cardiac example they will give, or they will also give you about post MI myocardial infarction patient scenario, and they will give you all the hemodynamic parameter and you have to mark it. Okay, so that is all about the hemorrhagic shock and cardiogenic shock differences. Now we will be going to management here, and in management always you have to maintain the airway patency with C-spine protection, and you have to intubate and ensure if the patient with Glasgow coma scale is lesser than 8 or airway at risk, you have to see, and breathing patency also you have to check. Assist in airway ventilation if necessary, and high concentration oxygen should be maintained, and identity and treat any chest injury, whether it is flail chest or whether it is any other chest injury, you have to maintain. And circulation, you have to control external bleeding, direct pressure packing tourniquet you have to place, and two large bore IV cannulas, 14 to 16G model you have to pick up, and you have to send the blood further to FBC, full blood count, or they may also give you CBC, you should not be confused, complete blood count, and urine and examination you have to do, and coagulation groups and cross match you have to do like ATPT, all those things you have to consider. And fluid resuscitation is very important, preferably crystalloid, and blood products if needed. MTP, it's a massive transfusion protocol, you have to know. Okay, disability, you have to check, monitor pupils and look for other causes of decreased consciousness. Okay, and exposure is fully expose the patient and prevents hypothermia. You have to ensure hypothermia, and if noted, how to make a warm blanket with fluid warmer and look for the other injury. Okay, so additional thing what you have to do is early control of bleeding is the most important priority, and maintain the systolic blood pressure 80 to 90 mercury pressure until the bleeding is controlled, and monitor is required with heart rate, blood pressure, respiratory rate, saturation pressure, oxygen you have to think, you have to monitor, and urinary output, that is target is greater than 0.5 millimole per kg per hour, and always this is the most favorite question for bleeding what you would be giving. The answer is tranexamic acid TXA early in the major bleeding, you have to think. So transfusion, you have to restore the oxygen carrying capacity and maintain the adequate tissue oxygenation. If you don't see risk of hypoxia, then target of hemoglobin should be 7 to 8 gram per deciliter. Okay, you can see the respective transfusion strategy, and transfuse only if the below target or symptomatic. Okay. Okay, in case of risk of hypoxia present, this is cardiovascular failure. Okay, ischemic heart disease, heart failure, severe respiratory disease, and active bleeding. You have to think about HB 10 gram per deciliter. Target the HB to 10 gram per deciliter. Okay, and higher target to ensure the adequate oxygen delivery, and consider individual patient factor. Okay, here transfuse red cell guided by HB level, ongoing bleeding, and clinical status you need to monitor continuously you need to monitor, and do not transfuse based on HB alone, hemoglobin alone, as you have to see the whole clinical scenario, and you need to make a monitor as I discussed previously, and use massive transfusion protocol if needed. And think about if you make an excessive transfusion, then it may lead to hyperkalemia. Okay. And next thing is component therapy is very, very important. So red cell transfusion restore the oxygen carrying capacity, that helps in restoration of oxygen carrying capacity, and plasma FFP. Okay, replacing clotting factor you have to know. Platelet maintains hemostasis. These are the two things you have to know in active bleeding. Greater than 50 into 10 to the power of 9 per liter, or greater than 100 into 10 to the power of 9 per liter in active bleeding. Okay, to maintain hemostasis you have to do. And cryoprecipitate fibrinogen replaced if fibrinogen is lesser than 1.5 to 2 gram per liter. Here we go to the question. First thing, in a question you have to know, in class 2 hemorrhage shock in a 70 kg male, one would not expect to find what, if you go to previous table, let me, okay, previous table I can see in class 1, class 2, right? Class 2. So blood loss is 750 to 1500. So blood loss should be greater than 750, okay, in ml. And next is pulse rate should be greater than 100, okay. And blood pressure is normal. Respiratory rate is 20 to 30, and urine output is also 20 to 30. This you have to know this. So here we will see all the possible answers. Blood loss is greater than 750. Yeah, this is correct. And here tachycardia is also seen. Okay, and decreased blood pressure. Okay, yeah, normal blood pressure, normal or slightly decreased blood pressure is seen here. And urine output is less than 20. This is not the case. Okay, and anxiety obviously. So this is D is the answer here. Next is after being stabbed in the left groin, previously healthy and 20-year-old man was admitted to the emergency department. He developed hemorrhagic shock during the resuscitation, and 10 unit of type O negative red blood cells and 6 liters of colloid were administered. 24 hours he was noted to have a severe dyspnea, for which he required intubation and ventilation on the intensive care unit. Which of the following would be most likely causes of respiratory insufficiency? So your answer is, this is the massive transfusion happened. Okay, massive transfusion with 6 liters of colloid, 10 unit of type O red blood cell, okay, with 6 liters of colloid were administered as per the given information, and 24 hours severe dyspnea and intubation and ventilation on the intensive care unit. This is none other than post-transfusion adult respiratory distress syndrome. You have to know. There is no evidence of trauma here. So tension pneumothorax won't be the presenting feature here. And there is no evidence of fever or COVID-like symptom. So viral pneumonitis is also not the possibility. And congestive cardiac failure also, there is no evidence here. And ABO incompatibility, definitely it would have happened immediately. So nothing. None other than adult respiratory distress syndrome. Okay. So patient loses 1.6 liter of fresh blood from the abdominal drain. Which of the following will not decrease? Obviously, I have explained about important hormone. One is renin, another is angiotensin, and other ADH. ADH is antidiuretic hormone. So in previously I explained about this. So ultimately renin secretion will increase. Okay, will increase, not decrease. Rest of all will decrease. Cardiac output decrease. Carotid baroreceptor I will be teaching you in upcoming session. And firing of aortic baroreceptor, this will also decrease. And next is blood pressure will also decrease. Only renin secretion will increase here. Thank you for watching. I hope you found this presentation helpful for your preparation. And if you enjoyed the video, please like, share, subscribe to the channel. Don't forget to leave your question or suggestion in the comment below. Stay tuned for more high yield topics. See you in next video.